Answer with Dan and Amy continues next on AM 560, The Answer.
Listen to AM 560, The Answer, online at 560theanswer.com, on the AM 560 mobile app, and your Alexa-powered smart speaker, on TuneIn, iHeart, and radio.com. When you've got questions, he always has an answer. It's Sean Hannity, this afternoon at 2 on AM 560, The Answer.
Good morning, Dan and Amy, and the good news out this morning that the Oxford AstraZeneca group has developed a vaccine they believe is between 62 and 90% effective, depending on the dosage. Sort of the handle is 70%. So this goes along with Moderna and Pfizer that are moving with alacrity to a vaccine to market. The head of Operation Warp Speed saying that he expects that first Americans will start to be inoculated with the vaccine, probably Pfizer's first to market, by like December 11th or 12th.
That's great news. Should we be celebrating this?
It would seem to be, but at the same time, we have ever more confiscatory lockdown policies, so it's a little bit hard to reconcile the two. But the vaccines coming online, of course, calls to mind a number of other logistical but also ethical issues, including, well, who should be first in line. For more of that discussion, pleased to be joined again by Dr. Sally Satel, a resident from the American Enterprise Institute. Dr. Satel, thanks for joining us again. Appreciate it.
Oh, thank you.
So on the distribution of the vaccine, particularly in the early stages, there's this rank order prioritization, and there's some disagreement among researchers. There's what Fauci's and the CDC and the National Academy of Sciences say, and there's what researchers at places like Johns Hopkins suggest about what makes sense in terms of rank order priority. How do you see the prioritization? And I know you've written about the insinuation of racial politics into this, which is, of course, inevitable but also dangerous. But, how we should think about the distribution of the vaccine, since not everybody who wants it can get it at the same time.
Well, it's very complicated, so by no means is this easy, and it's completely expectable that there would be some controversy because, public health experts and bioethicists are really juggling four considerations, especially if they're thinking about this in terms of groups, which groups to prioritize. And the first is, who's at high risk. Actually, I'm not even putting these in rank order, just saying one is group risk, which groups are at the highest risk of exposure, which groups play the most critical role in maintaining the healthcare system and keeping society running, which groups are most likely to transmit the virus to others, and who's most likely to die. And it's not clear which go first, with the exception, I should say, of healthcare workers. There's pretty much universal agreement that healthcare workers who were exposed on a regular basis, would come first. And there's also general consensus that those with vulnerable illnesses, those who are immunosuppressed, those with cancer, other kinds of conditions would go first. Those vulnerabilities make them more susceptible, both to probably infection and also to dying if they catch it. But after that, it's complicated. In the UK, for example, they're considering prioritizing after that by age. I've heard some suggestions that maybe we should do it by zip code, because the real point when it comes to other vulnerable groups are people who are, exposed in the course of their daily lives. They're not people like me. I'm very fortunate I can work from home. These are folks who have to take public transportation. They are in jobs where they interact with the public a lot. They often live, if they're lower income, they may live in households that tend to be crowded, and all these put people at risk. And in fact, the National Academy National Academies of Medicine actually do suggest that we prioritize according to a social vulnerability index that takes into account poverty, unemployment, health insurance, other socioeconomic vulnerabilities. And I think that makes sense because fundamentally we want to prioritize by who is at risk. And this is where the suggestion that we might give some priority to people according to race becomes problematic, because even though race does correlate, at least African American and Hispanic race ethnicity does correlate with rates of infection, there's no question about that, and even mortality. It's really the risk. It's really the fact that these folks tend to be disproportionately represented in the lower income groups, in those groups I mentioned before that have to take public transportation and work in jobs that are with the public and so on. So it's really the risk that is the cause. The race is just the correlate. And when we're working with public health, we have to pay attention to cause.
And where do children come in all of this, and teachers, and hopefully getting back to some normalcy with kids actually learning with their teachers standing in front of them?
Yeah, I thought a very smart op-ed in the Wall Street Journal last week suggesting that teachers be right under, if you're rank ordering, close to the top.
Yeah.
And frankly, I think that makes a lot of sense. I hope.
Well, how does that make? Well, wait a second.
Yeah.
So this is my confusion in these discussions. So how does that make sense if it's based on vulnerability? Because we know what the incidence of transmission is professionally for teachers, to the extent that they're even in the classroom at present. It's the same thing that daycare workers I saw listed in the top 3. Why? There's a Yale study of 57,000 child care centers that found basically nil transmission. So I mean, I get theoretically you say, oh, well, teaching is important, so we want to inoculate teachers. Yeah, okay, I agree, teaching is important, but if it's based on the risk that you present, the environment and the risk, then actually teachers and daycare workers doesn't make sense in terms of priority.
Well, I did mention at the beginning that there were about four kinds of imperatives to juggle, and one of those 4 was what is the group that plays a critical role in maintaining society, and teachers and kids being in school so their parents can work has a big role in maintaining the economy.
Yeah.
So that's another variable to juggle.
Right.
That's why it's so darn complicated.
Well, yeah, I mean, right. I mean, it's darn political, which is why it gets darn complicated, I suppose. I mean, Johns Hopkins takes interestingly, I thought, a bit of a counterintuitive approach. They said actually prioritize young people, even though their risk is low. That you have you put them back into a general population, as it were, put them back into society, and actually with them inoculated, that it overall reduces the spread, and it will ultimately lead to more lives saved.
Yes, and again, I come back to those 4 things I mentioned, and the one was, are certain groups more likely to transmit the virus than others? And those would be the kids, exactly, because even though they themselves are not that vulnerable to illness, yeah, they can. So that's why it's so tough. But when I was focusing on risk, I was thinking in the context of race, and that's where race itself does not increase risk. It's the social correlates of race. In other words, again, the social vulnerability.
Right,
But,
and as you mentioned in your piece too, that the whole race thing, you can play the race card a few different ways. On the one hand, you say, well, it should be blacks and Latinos first because of the higher incidence, and as you say, the correlation between socioeconomic status. And on the flip side, you get some Black Americans saying, "Well, wait, I'm not taking the vaccine first. I'm not going to be your guinea pig." I mean, so some people you can't win for losing.
Well, that's true. That's very true. Frankly, there's not enough, I think, willingness to take the vaccine among all Americans. I mean, even among whites, when asked by, I think it was a Harris stat poll, and they were said if the vaccine were over 90% effective, and this was before the Pfizer announcement. So they weren't, I think, even anticipating could have such potential success with it. And they said if it were 90% effective, only 2/3 of all Americans would take it, and it was about 50% for African Americans. And so, frankly, everyone, I would hope the vaccine hesitancy would start to melt across the country, but it is the resistance is disproportionately higher among African Americans, and they will invoke the Tuskegee experiment from, that ended in 1972, but that's a classic example of abuse of a group to allegedly advance science. It had to do with, it was a syphilis study in which
yes, right.
Yeah,
but I mean, but
treated.
But what that really speaks to, which is sort of interesting, because I think that there's a that speaks to, thinking about the Tuskegee experiments, is I don't trust the public health officials. I don't trust the institutions. And what you have here now across the board, that transcending racial categories, maybe from different angles, but transitioning races, a lot of I don't trust because of the pronouncements made by so many public health officials, like that this was received wisdom from on high, that has turned out not to be received wisdom, and has turned out to really be the only end result is not necessarily saving lives at all, in addition to negatively impacting the quality of my life for an extended period of time, much longer than was initially suggested.
Right, there is a lot of distrust, and that's actually a kind of a free-floating problem that doctors and public health have to deal with. But in this particular example, I think it was also exacerbated by, ironically, the name of the operation, Operation Warp Speed, which sounds great, and it was Warp Speed, and it's all apparently, we're not done yet, but it looks so promising, and this seems like an enormous success, but the name implies that we rush this through. And so some people are cautious about that. And then there was an animosity towards President Trump. And so anything that he was behind, and especially to the extent that he wanted this revealed before the election, that didn't happen. But that also created, a fair amount of anxiety and suspicion as well. So, yeah, it's clearly very much a social phenomenon as well as a medical one.
And Doctor, I wanted to go back to something that you said earlier about kids. They're not vulnerable, but they can spread the disease to people at home. Are there any proven cases at all of student-to-teacher transmission or student-to-parent transmission that you know of?
I wouldn't say kids are not vulnerable, but they're much less vulnerable to becoming sick. And I'm not aware, but that doesn't mean it doesn't exist.
Okay. With respect to that trust issue and credibility, do you find this to be the case? The unwillingness to incorporate studies in discussions that run against whatever the countervailing wisdom is. I should say whatever the prevailing wisdom is. There's no opportunity for any countervailing input. So, for example, over the last couple of weeks, 2 studies, one from the Icahn School of Medicine at Mount Sinai, another from a group of Danish researchers, that suggest that mask wearing is basically ineffective. It basically has no impact. In point of fact, in the Icahn study done with the U.S. Marines, those U.S. Marines that did not wear masks were infected at a lower rate than the Marines that were on lockdown wearing double cloth masks or double surgical masks for the period of the experimentation. But yet I don't hear any of that conversation. All I just hear is more mask zeitgeist. Even your colleague, Dr. Scott Gottlieb, over at American Enterprise Institute, writing the Wall Street Journal over the weekend, is not reconsidering mask wearing as some sort of half-ass panacea, to be blunt about it. But he's talking about, now we need to wear better quality masks. Well, right, because we know an N95 is better than a surgical, is better than a cloth. Well, I know we've known that for 8 months. So why are you saying it now? What's the magic now? The unwillingness to address peer-reviewed academic studies that don't comport with the policy you're currently proposing, I think, is a real credibility destroyer.
Well, I think you're right about that. I think we still have a lot more research to do, but often when things get presented in the media, as if this is the final word, when often they are kind of provisional words. And so then when another study comes out that disagrees with it, it's confusing and people get whiplash. And then, of course, these studies are very complicated, extraordinarily complicated to parse. A lot of times they're done with models, and models are only as good as the assumptions, and sometimes the assumptions are wrong. So sometimes it's not that much of a surprise that you get different answers, but it's incredibly confusing to the public. I understand that, and I believe I was on your show after George Floyd, and we talked about, and to me, this is frankly still one of the most stunning statements I've ever seen by a public health official, or she was an academic, but a much quoted academic at Johns Hopkins, that I'm paraphrasing only slightly, but it's okay to get out there and march because this is a good cause.
Right.
And that was before we realized, you know, if you're outside and you're not on top of someone else screaming, you're probably going to be okay. I mean, the march 2 weeks ago, was it last week? Here in Washington, D.C., the Trump supporters.
Oh, yeah, right.
A lot of them are wearing masks, and they were. The point is, you know, we're not hearing about outbreaks from that. So.
And it's, you know, it's just the larger issue too. Anybody who says the science, to your point, anybody who says the science is settled is not a serious person, because the science is never settled. That's the point of science. But yet we're told by these politicians and these TV scientists that the debate is over, the science is settled, even as research is going on that's finding out new things or finding out things that we thought were new or old.
Yeah, you just actually touched on one of my pet peeves, is the way people use the word science. Science, when they say science says, I understand what they mean, but it does imply that this is a definitive result, and in many cases, as you say, it's provisional, and science doesn't say anything. The data say something, and those data, as you note, can change over time as we know more. Science is a methodology. It's how we approach a question and try to look at it in the most controlled way and account for other variables that can produce an outcome, but it's a method, and it's the data and the evidence that show you something, and that evidence is often, not always, I mean, some evidence is just pretty darn solid, and we should follow it, but there are certain topics where